Good afternoon, everybody, and welcome to our chat today about orthostatic intolerance. And over the next little while, we'll cover a little bit on diagnosis and management of this terribly debilitating condition. So we'll talk about some definitions today, a little bit of background information about orthostatic intolerance, just a little bit of information about why what's going on and why people feel as symptomatic as they do. And then we'll look at how a diagnosis is made, and then follow that with some management strategies. And luckily, orthostatic intolerance can be very well managed if we apply all of the resources available. So first of all, what is orthostatic intolerance? Well, it's actually an umbrella term for several conditions where people become symptomatic or start to feel unwell when they assume and maintain an upright position. So it's actually getting up, but then often when you're staying upright in the upright position, the symptoms continue to get worse. It usually is when people are standing, but for some people who have quite severe symptoms, it also can be brought on by prolonged sitting. So it's that upright position. And people usually improve with lying down, particularly if they have their feet up, although some symptoms can take hours or days to resolve, including fatigue and brain fog. So orthostatic, all that is a word that means relating to or caused by an upright posture. And orthostatic, or OI, we'll talk about OI quite a bit, is common in MECFS and long COVID, hypermobility spectrum disorders and Ehlers-Danlos, and also can be seen in fibromyalgia as well. So the two main types, as we said, there's several types. It's an umbrella term for several types of conditions, but the two main types that we talk about when we're talking about orthostatic intolerance are POTS, which is postural orthostatic tachycardia syndrome, and neurally mediated hypotension. So POTS is one of approximately 15 types of dysautonomia, and it stands for, and as you can see down there, the P is for postural, which means relating to the position of the body. O is for orthostatic, which means upright. Tachycardia, a fast heart rate, and syndromes are that group of symptoms. So the word POTS encapsulates all of those things. Neurally mediated hypertension is a drop in blood pressure after being upright, but it's a different hypertension from postural hypertension, which is very common and which typically happens within a few moments of standing up, often when people sort of stand up very quickly, and it's as the body kind of regulates itself, and then the hypertension will disappear. So the postural hypertension is very often after standing up, whereas the neurally mediated hypertension typically hits a little bit later on. So those are the two main types, is POTS and NMH. So just a few facts and figures about orthostatic intolerance. So the good news about it is that more than 50% of people who got orthostatic intolerance as a result of a virus get better within 5 years. So for those people, the outlook is extremely good for full recovery. Again, the good news is that people, 80 to 90% of people who get treatment have some symptomatic improvement. So there is improvement in their orthostatic intolerance. But the bad news is that about a quarter of people are so disabled by it that they can't work, and it's probably very underdiagnosed. We don't really know how many people there are who have it. The average age for onset for POTS is about 20, and it's much, much more common in females than males. And often when people are talking about orthostatic intolerance, it's kind of synonymous with POTS, although, of course, as we said, there are many types of orthostatic intolerance. So POTS, what is it? It's an exaggerated increase in heart rate when people are in an upright position. So it's the heart rate goes up quite abnormally, but the blood pressure remains fairly much unchanged. And the increase for diagnosis must be 30 beats per minute or more, sustained over 10 minutes. And for adolescents, that's a bit higher, it's about 40. And so the heart rate typically, when people are standing or in an upright position, is over 120 beats per minute, although the resting pulse remains normal. So you get the increase in heart rate, and then this is accompanied by orthostatic symptoms. So that means the dizziness, the heart pounding, the black vision, the anxiety, all of the weakness, muscle weakness, all of those things must accompany the increase in heart rate. So the thing to remember about POTS is that the increased heart rate, the abnormality is the regulation of the heart rate. So it's the regulation of the heart rate that is abnormal. The heart itself is usually totally structurally normal. There's nothing wrong with it. And I think that's a really important fact to hold on to, because people feel so horrible when they have the palpitations, the pounding heart. I had someone say to me recently, I thought I was going to die because it just felt so awful. I felt like my heart was going to sort of give out and I was going to die. But the heart is structurally normal. It's the regulation of the heart rate that's abnormal. And then sometimes people will also refer to subtypes when they're talking about POTS. Now, this isn't always the case, but it can be, sometimes it can be a wee bit helpful in terms of just trying to see kind of where you sit in terms of your symptoms. A lot of people have all of these symptoms, but some people do have quite defined subtypes. And so there's the neuropathic POTS, which really is about poor nervous system control of your blood vessels in your lower leg. So there's problems with that nerve control of the blood vessels. So you get a lot of blood pooling, and these people who have this are more likely to have the blue, or red, or purple feet when they're standing or when they're warm. The hypovolemic POTS is about a low blood volume, so both in plasma and red blood cells. So you actually have less blood. And that's characterized more by weakness and decreased exercise tolerance. And then you have the hyperadrenergic POTS, where you've got really high levels of epinephrine or adrenaline and norepinephrine, and that's where you get the sort of the heart pounding, the sweating, the trembling, the high, very, very high heart rate. So as I said, there's a huge amount of overlap usually. Most people have all of these symptoms, but sometimes it's helpful to sort of think about these as different kinds of subtypes, and that can be sort of helpful in working out what your treatment choices are going to be. So neurally mediated hypertension is a drop in blood pressure, whereas POTS is an increase in heart rate. The neurally mediated hypertension is a drop in blood pressure that happens after you're upright. And it has to be 25 milligrams or more of the systolic blood pressure, which is your top reading. And most people who get this have quite a normal resting blood pressure. So neurally mediated hypertension is an abnormality in the regulation of the blood pressure rather than the heart rate. And it happens because there's too little blood coming back to the heart when people are upright, and then that triggers sort of a series of abnormal interactions between the heart and the brain. Neurally mediated hypertension and POTS can occur together, although they are two quite distinct processes. And it's a little bit unknown, why people will tend to get one rather than the other, because they are initiated by the same faulty mechanisms. But some people tend to go to POTS and some people tend to go to neurally mediated hypertension. It's the most common cause of recurrent fainting. So people that faint a lot, this is probably the most common cause for it. And it's seen more in younger people who have a low to normal blood pressure, and seen also more in people with MECFS. It also happens following infection, and sometimes you can get groups of family members who have this in common. And with family members, if you have this, the resting blood pressure is often lower than normal. And the thing about it is that it may not be detected unless you have a prolonged, what they call orthostatic stress. So it commonly happens. So you have to be standing and you have to be quite still for a long period before the changes start to happen. And in a test situation, this could take up to 45 minutes. And it's definitely the less common kind of orthostatic intolerance. POTS is one that's seen much more commonly. So here's just a little simple kind of a diagram, just kind of explaining how it happens. So after an extended period of standing, you get the heart and brain miscommunicating and the blood pressure drops. The third kind of orthostatic intolerance, I guess, is just called low orthostatic intolerance. So in this situation, you have symptoms, but you don't have criteria for POTS or NMH. And this is probably because of low cerebral blood flow. So people are not getting the brain perfusion that they should be getting, that would normally happen. And 60% of MECFS patients have normal blood pressure and heart rate when tested with an orthostatic challenge, but many of them do actually have symptoms, orthostatic symptoms. And the reason for this that they found is that normal people, controls, when they test them in an upright position, have a 7% reduction in blood flow to the brain, whereas MECFS patients have a 24% reduction in blood flow. And so this is, a very possibly why many people with MECFS have low orthostatic intolerance. And with this low orthostatic intolerance, the symptoms are as severe and as debilitating as those who have been diagnosed with POTS and NMH. So causes, what's the causes of POTS or orthostatic intolerance? Well, the cause and management remain completely understood, basically, is the short answer. But they have noticed that in up to 50% of cases, the onset followed a viral illness, and very common post-COVID. It may be linked to physical trauma or concussion, even pregnancy, surgery, ongoing psychosocial stress. And it's thought that these events might trigger an autoimmune response, which can cause it. It's more common in females. There seems to be a genetic link. Certainly physical deconditioning is a factor, and it is seen, orthostatic intolerance is seen in people who, after a long illness or who've become very weakened or rapid weight loss. But that is sort of quite reversible once those issues are addressed. It can be, as a result, POTS can be a result of a secondary condition, and it can co-occur with all types of Ehlers-Danlos syndrome, and it's often associated with mast cell activation syndrome as well. So what's happening when an orthostatic intolerance? So as we said, it's an abnormal response to people who have, when they're in upright position. And there's a lot of multiple sort of interacting stuff going on, and it can include dysautonomia, it can include low blood volume, and it can include increased levels of epinephrine and norepinephrine. So when we're talking about the dysautonomia, it's helpful to think about what that relates to, and that relates to the autonomic nervous system. Our autonomic nervous system is entirely responsible for all of the involuntary things that go on in our body, our breathing, our heart regulation, our bladder control, our bowel function, our digestion. All of those things are controlled by the autonomic nervous system, and it has two parts to it. The sympathetic nervous system, which prepares our body for flight or flight response and stressful situations, and then the parasympathetic nervous system, which is works in opposition to it and helps the body to conserve energy and recover. And it's totally unconscious. We can't. It manages all of these functions without conscious effort. And here's just a wee diagram that sort of shows how the parasympathetic and sympathetic nervous system, sort of work in opposition. So on the left-hand side, we've got the sympathetic nerve, parasympathetic, and on the right-hand side, we have the parasympathetic nervous system. So if you're having a look at the eyes, for example, the parasympathetic nervous system constricts the pupil. So when it's constricted, you're in a relaxed state. On the right-hand side, the sympathetic nervous system dilates the pupil to let in the maximum amount of light so that you can see, as well as can be expected. You're giving your eyes optimum ability to see and react to things. The parasympathetic stimulates salivary flow, so that, first stage of digestion, whereas the sympathetic inhibits it. The parasympathetic slows your heart rate and has in a relaxed state, whereas the sympathetic accelerates the heart rate and constricts our arterioles, which are our very most distant little blood vessels, to make sure that the blood moves away from extremities and into the vital organs where it'll be needed, etc., etc., etc. So as you can see, they're totally opposing, and they're always acting together in sync to maintain our body systems. And here's just another wee kind of summary. So the sympathetic nervous system is fight or flight, cortisol, adrenaline, increased heart rate, decreases digestion. The parasympathetic, rest and digest, calm, hormones, decreased heart rate, etc., repairs the body. And you can see that when things are out of sync, that very often it's the sympathetic nervous system that can dominate, and it really explains why people feel the way they do when things are out of sync. That sort of very anxious, hyper alert, hyper excitable sort of state. So dysautonomia is the name for the group of disorders where the autonomic nervous system doesn't function as well as it should. You can have dysfunction in either arms of the nervous system. It can be really unpredictable how the body can be affected. And POTS and orthostatic intolerance are two forms of dysautonomia. So when we're talking about dysautonomia, it's that umbrella term for that. So what happens when we stand upright? So in a normal position, a normal person, and when we say normal in inverted commas, of course, in a normal person, gravity causes a bit of a drain of our blood. So there's a little bit of pulling in our legs, abdomen, and arms when we stand. And that can result temporarily in a little bit of less blood to the brain. And that's when you have that less blood to the brain is when you start to see stars, or your vision tunnels, or it gets blackened. It blackens, prior to a faint. But that's usually very temporary and usually doesn't occur at all, because the reflexes that are involved take over so quickly. Leg muscles pump blood back to the heart and brain, and the body turns on a series of reflexes, which is usually about epinephrine and norepinephrine release. And what happens is they're released, they act directly on the heart to pump harder and directly on the blood vessels to constrict, so that the blood can move more quickly along to the heart and brain. So this is a series of actions that happens very smoothly and very quickly, and most people, when they stand upright, aren't even aware of any of that going on. They just move from one position to another without any effect. When people with orthostatic intolerance stand, everything is delayed and a little bit out of sync. So first of all, more blood pools below the level of the heart. It can be anywhere from 500 to 750 mils pooling in your legs, in your arms, and lower abdomen. People with orthostatic intolerance also have, very frequently, a lot of people have less blood volume. And both of those things, the blood pooling and the low blood volume, trigger increased amounts of epinephrine and norepinephrine to be released. What happens is that the effect on the blood vessels is inefficient. So they either don't constrict well, or they don't constrict at all, they actually dilate. And the increased epinephrine and norepinephrine in POTS causes the heart rate to increase to try and get the blood moving around the body and perfusing the brain. And in neurally mediated hypertension, that increased epinephrine and norepinephrine somehow causes a miscommunication between the heart and the brain, and the blood pressure drops. The blood vessels dilate and your blood pressure drops. It's not clear why people react differently to the same kind of stimuli, but it's thought that it might have to do with the balance between the epinephrine and norepinephrine. And again, looking at the subtypes, so in POTS, people with the low blood volume, who is their main issue, have the hypovolemia and the neuropathic POTS kind of react in the same way, because they're both about blood pooling. And what happens is that the heart increases tries to increase the cardiac output by beating faster. So you get the blood pressure, the heart rate going up because of trying to move the blood that's pooling in the body. In the hyperadrenergic POTS, there's a lot of epinephrine levels circulating in the blood, and that works directly on the heart to make it pump harder and faster, and you get that increased heart rate because of the hormones. So how do people feel? What are the symptoms of orthostatic intolerance? So for those who have the reduced brain blood flow because of the pooling, you get a slightly different effect from those who have the high levels of epinephrine and norepinephrine. So reduced brain flow causes things like lightheadedness, fainting, really poor concentration, nausea, fatigue, a lot of muscle weakness, blurred vision, headaches. The headaches are really prominent, whereas the epinephrine is all about the pounding heart, the shortness of breath, the feelings of chest discomfort and palpitations, anxiety, sweating, and nausea. So they're slightly different expressions of how you might feel. Some people get all of it, some people get the whole lot, some people might just get one or two symptoms. And what are things that bring on the symptoms? And it's really quite important to know about this, because that's probably the first thing that you would be doing in treating your POTS or NMH is, how do I avoid my triggers? So you've got to identify what they are. But people being in a quiet, upright posture, so they're just standing still very quietly or sitting still for a long time. A warm environment, a shower or a hot day, because what that does is it dilates your blood vessels. So again, you're not pumping the blood around as efficiently. Immediately after exercise, especially if you're not warming down properly. Emotionally stressful events can be a real trigger. And for some people, it's eating really big meals that take a lot of digestion, because that just directs all the blood flow to the digestive process and away from the extremities and the brain and stuff like that. Low fluid and sodium intake, pain after drinking alcohol and caffeine as well, actually, because the alcohol is the vasodilator. And both alcohol and caffeine are diuretics, so you're passing out more urine. And after prolonged bed rest, so even first thing in the morning sometimes can be the worst time for some people when they first get up. So how do we diagnose orthostatic intolerance, and how do you know if you have POTS or if you have neurally mediated hypertension or what? Well, the first thing to do is to have a really good assessment and rule out other causes of things that might be contributing to feelings of dizziness and being unwell when standing. Checking for rapid weight loss, and as I said before, the rapid weight loss, or people who've been in bed perhaps after an illness, have become very deconditioned. It's important to take that into account, because once those things are reversed, once they start to get back a bit of strength and a bit of weight, the symptoms disappear. These symptoms are often quite common in adolescents too, especially after a growth spurt. And again, they usually disappear with time. It's important to check medications, because some of the medications can really cause symptoms and make them worse. And it's important to remember that in the past, POTS has been incorrectly labelled as anxiety, because of course all of that feelings of sympathetic nervous system hyperactivity do sort of mimic how you feel when you're anxious. And diagnosis, once you've ruled out all of those other things, is actually very simple. It's pretty much a 10 to 15 minute test, and it can be done as a tilt table test, which is what is the gold standard of POTS diagnosis. There are 3 places in Canterbury where you can get this done, including the Funny Turns Clinic at the Canterbury Hospital. And basically, your blood pressure and pulse are taken 2 or 3 times when you're in a lying position, to make sure to establish a baseline, and then you are tilted into a 70-degree angle, and blood pressure and pulse are recorded every minute for 10 to 15 minutes. If neurally mediated hypertension is suspected, then you would be left in that position for longer, and recordings would be done more often, and probably for up to 45 minutes. So that's the tilt table test, which is recognised as the gold standard. But there's also the Nasoline test, which is done very easily in the home or in a doctor's surgery or in an office, and it has a high degree of accuracy for diagnosis. It gives just as good a result as the tilt table test. And again, same thing, you lie nice and quietly for up to 20 minutes, have your blood pressure and pulse taken for 2 or 3 times to establish a baseline. Then you stand up, leaning against a wall for 10 to 15 minutes, and blood pressure and pulse are taken every minute for 10 minutes and recorded. And that is enough generally to give a very clear indication of what's going on with your blood pressure and pulse. The other preparation for this is to reduce fluids and not take some medications the night before this test as well. And in addition to the 2 diagnostic tests that are done, or it's 1 diagnostic test done slightly differently, there are 2 kinds of questionnaires that can be completed, which are really good for communicating the degree of impact that orthostatic intolerance has on your lifestyle, on your functioning. So the first one of these is hours of upright activity, which is a questionnaire really, and it's about identifying the number of hours that your feet are on the floor each day, and that includes sitting and standing and walking and moving. So how many hours in a day are you upright? So it's actually about recording that, and it's a really good way to determine the level of functionality, and it's also a really good way to evaluate if your treatment is making a difference. So it's good to have this as a baseline before treatment, to fill out this form or make a recording, and then after you do some treatment, particularly if you're starting medication, repeat the questionnaire, and you can really see quite objectively if it's making a difference. So interestingly, you can see I've got some figures there. So healthy people typically would have 14 to 17 hours a day of upright activity. People with a chronic illness, including fibromyalgia, that's sort of reduced to around 10 to 12. And they have worked out that people with MECFS can be anywhere from 0 to 8 hours a day of upright activity. So that's really shows very, very clearly the kind of impact that illness, and particularly orthostatic intolerance, has on your life. And there's another questionnaire that can be done either with or without the hours of upright activity. It's called the Orthostatic Intolerance Questionnaire, and it has 2 sections. One section, you score out of 0 to 10, and you sort of think about your past week, where you would be sitting in the past week on each of the indicators. So on one side, there's orthostatic symptoms assessment, which includes, how dizzy you've been, the degree of fatigue, weakness, how your vision's been affected, concentration, and head and neck discomfort. So it's 6 indicators. And then on the other side, it's looking at your daily activity scale. So how able are you to stand for a short time? How long can you stand for a long time? Walking for a short time and walking for a long time, how impacted are you? And again, this is a really good tool for just communicating to healthcare professionals the degree of impact that you are suffering from orthostatic intolerance. It can be quite a powerful tool, I think, to show that degree of loss of function. So the good news about orthostatic intolerance is it's one of the most treatable conditions associated with MECFS, and there are lots of things you can do. You can't be, it's not a cure, but everything that you can do can help to improve management. And what you're trying to aim for is to get better function, and that's to be able to stand more, to be able to do more, and to increase your exercise tolerance a little bit as well. And there's 5 main kind of strands to the management. The first is volume expansion. The second is mechanical methods. There's a whole list of miscellaneous stuff, and there's exercise, and there's medication. And just a little summary of probably the most important essentials for people with POTS: electrolyte drinks, salt, compression, and recumbent exercise. So the first thing that we were talking about was volume expansion. What we're talking about is getting more fluids, increasing your blood volume, basically. And it's probably the most important thing that you can do, and it's probably the most effective thing that a lot of people can do. And for some people, this is enough. It's important to be quite aggressive about it, to aim for about 3 litres a day of fluid. And you have to, with your water, you have to have sodium as well. Otherwise, it's fluid in, fluid out. And it's a really good, I think, indicator to have a look at how do you know you're getting enough. And you should be able to pee for at least 20 seconds. It shouldn't be any darker than a light yellow colour, and you should be going probably 5 to 6 times a day maximum, unless you have other sort of issues. So 2 to 3 litres of fluid a day, and then half of that fluid intake, you should have it with electrolytes. So we're talking about sodium plus a few other little electrolytes, but for the orthostatic intolerance, sodium is the important thing. Salt has got about 40% sodium in it, so we're not talking salt equals sodium. Salt has sodium in it, and we're aiming for 6 to 10 grams of sodium a day. So when we're thinking about what that looks like, the normal New Zealand diet, when we're talking, I guess we're throwing in a few takeaways and a little bit of salt with the veggies and a bit of processed food and stuff. Our normal New Zealand diet is around about 3.5 grams of sodium, and 1 teaspoon of salt is 2.5 grams of sodium. So if you start by adding 1 teaspoon of salt to what you normally eat, you're probably going to be sitting at around about 6 grams of sodium a day. And why do we need the sodium? Why is it so important? It's because it increases the blood volume. So what it does is it makes us retain more of the fluid that we're drinking in our blood vessels, and therefore we get a healthy blood pressure, and it helps. The increased volume helps when the body's trying to adjust to all of those things like pulling and faster heart rate. High salt diet has had bad press in the past. It's sometimes seen as unhealthy. We sort of think high fat, high salt. You hear those things talked about in the same breath, but high salt is not good if you have high blood pressure or kidney disease. But for someone with orthostatic intolerance, a low salt intake is more likely to be unhealthy. So how do we get the electrolytes or the sodium? So you can buy sodium chloride tablets over the counter. They're not that palatable. They can make you have a bit of a tummy upset. Some people find they get the runs with it. So another option is to get it through electrolyte drinks. So you can get your electrolyte sachets, which you can buy over the counter or on prescription. You can get Electro 3 months supply on prescription. Sports drinks have high sodium and high electrolytes in them, but they also typically have high sugar, so really important to be aware of that. Some people actually find their teeth do suffer, and if that's a problem, it can be, you can drink it with a straw, can have less impact on it as well. A lot of the electrolyte drinks have different amounts of sodium, so really, again, read your labels. Some of them are a lot higher than others, so go for the high ones if you can. And it can be really helpful to, if you're going to do activity, particularly if you're going to swim, to shower, or have to stand somewhere in a queue for a while, pre-hydrating with electrolytes can be really helpful to help you get through those activities. And if you're starting to feel yourself getting a bit symptomatic, it can be a really good rescue supplement as well. So how do we increase salt in our diet? There's lots of ways you can do it, lots of good snack ideas that you can use, dried foods, scrambled eggs, olives, salted nuts, a lot of those drinks like broths and Marmite, I guess. I know someone used to have Marmite drinks and they're quite salty. V8 vegetable drinks, pickle juice, use your soy sauces and things on your food freely. And a lot of soups, a lot of foods can absorb salt, a lot of salt before tasting too bad. So, and it's quite a good idea to use those as well. And as you see, I've taken some of these suggestions from the Dysautonomia International webpage. They have quite a few recipes on there as well. So that's all about the volume expansion is fluids and sodium, and probably one of the most effective things you can do. But other things you can do, particularly if you have recognised that your issue is with pooling of blood, is to use mechanical ways of moving your blood around as well. And probably the most effective way of doing that is wearing compression garments. And the more skin you cover, the more effective that will be. And they work best if they're put on first thing in the morning. And yeah, they can be really helpful in terms of increasing the blood circulation. If possible, sleep with the head of the bed slightly elevated. And this, the mechanism behind this is that if we are sleeping a little bit elevated and not with our bed too flat, that the kidneys will actually produce less urine overnight, and therefore you're waking in the morning with more blood volume. You're not losing so much fluid through your urine. And again, postural counter manoeuvres. So if you're standing and you're starting to feel a bit dizzy and a bit woozy, just pumping the muscles in your lower body, contracting and releasing, contract and release, can be enough to really move some blood up your legs. And you can actually move probably about 500 mils of blood quite effectively by just doing some of these things, crossing your legs, pumping your heel and toe, clenching your buttocks, clenching your thighs. Those sorts of things can be really good at moving some of that blood. So avoiding some of the other things that we can do is avoid the overheating. So cooler showers, avoid spas, be careful in heated swimming pools. Managing triggers, particularly if you know that emotional triggers and things are going to be, or stress are things that make you feel worse. Equipment, showers still can be really game changing, and as well a perching stool in the kitchen. I've had people feedback to me that it's just made such a difference in terms of what they can, how they can improve their function. They can actually get through and prepare a full meal without having to constantly sit down. Consider hiring a wheelchair if you're going to go out for events and things. That can be helpful as well. Chugging a large volume of fluid before a shower or before a time when you have to stand still for a long time can actually help get your blood pressure up. And overseas, certainly, I don't know if it's used as much here, but overseas intravenous fluids can be used as a rescue for people who need to have a bit of recovery, or in terms of prevention if there's something coming up and they need extra blood volume. Avoid alcohol and caffeine, we've talked about already, and large meals, and just sort of common sense, change your position slowly when you're getting up. And here's just a few wee tips for that shower, because that can be an extremely challenging place to be when you have orthostatic intolerance. So every little tip can make a wee difference in how you can get through your showers. So exercise is the fourth strategy to help with POTS. And for people who don't have MECFS, this is something that can be pursued quite vigorously. So when you are exercising, if you have MECFS, it's really, really important to be very aware of not causing post-exertional malaise. So you approach it sort of slowly and very, very carefully. The best exercise, whatever your background, the best exercise with POTS is to start lying down or recumbent and avoiding that orthostatic stress. Gentle exercise in water can be really helpful. Make sure that you hydrate well beforehand and wear your compression garments. And the sorts of exercises that you can start on are things like stretches or yoga or gentle weights from a seated position. Recumbent biking and swimming are two forms of exercise that can be really, really useful if you can tolerate exercise. And the recumbent biking, you can get those, you see there in the bottom corner, those little portable bike wheels. You can buy them at Kmart for about $40. But again, start slow, start low, and monitor very, very carefully if you're going to sort of be exercising. But anything you can do for your lower body to tone it up will be helpful. And then don't go to upright exercise until you work up to it. So don't go to your upright exercise until you've really got your recumbent exercise well mastered. And again, if you wanted to look more into it, the Dysautonomia webpage has got some really good specific recommendations and some sample exercise regimes that might be helpful. And the last arm of management of orthostatic intolerance is medications. And it's always important to think to use those, to go to those when you've tried all of the other measures first. It's really important to get all of the other ducks lined up in a row before you go to medication. It may be that there are a number of kinds of medication that are available. So the first medication may not always be the one that works for you. So always keep that in mind and go back and have further discussions if you're not finding improvement. And sometimes it's combinations of medication that make the difference. And there's 4 different sort of really groups of medications. The first are the ones that increase blood volume, and fludrocortisone is the one that is probably the first go-to for treatment, and it's probably the most common medication that's used, and often is, it's all that is needed. There's some other medications there that are not first-line treatments, but if you're on them, you'll find that they also increase blood volume. So you might get that as a secondary effect. So the oral contraceptive pill, for example, increases blood volume. So people often feel better when they're on that. And same with clonidine and vasopressin medications that have the blood volume increase as well. The next class of medications are the ones that interfere with epinephrine or norepinephrine effects. And these are the beta blockers like atenolol or propanolol or bisoprolol, and also ACE inhibitors as well. The next ones are the ones that improve vasoconstriction. So these are people having faulty nerve control of their blood vessels in their legs. And the midrodine is the one that's used mostly for that, and that's a medication that you have to take 3 or 4 times a day. And it's really important when you're taking it not to take it before you go to bed at night, because it can make your blood pressure go down too low. But that's can make quite a difference. And again, incidentally, if you're on something like sertraline or escitalopram, they have that same kind of effect of improving vasoconstriction, so therefore you can have that secondary benefit from them. They wouldn't be a first-line treatment. And last of all, there's mestinon, which is a medication that's been around for a long time to treat a condition called myasthenia gravis. And they've found that this, used off-label, is also can be very, very effective in treating orthostatic intolerance. And yeah, it improves the venous blood return to the heart and oxygen delivery to the tissues. So that again can be a really effective treatment. And I've just got here, it's a very busy slide, and it's probably just more for reference if you wanted to come back and have a look at it. But again, when we're talking about the subtypes of POTS, it just sort of looking at how you would tailor the treatment depending on which type you thought you might fit. But as I said, most people have overlap anyway and do have a little bit of everything. So this is really only useful for people who can sort of definitively say, well, I've got hyperadrenergic POTS, I know, because I fit all of those boxes and nothing else. Yeah. And just the last sort of mention of vagus nerve stimulation, because that is something that has been in the news, and I guess on the horizon a little bit. It has been used for other conditions, and there have been a few sort of small trials to see if it does make any difference to orthostatic intolerance. So, and the way that it's done, as you see in the picture, is that there's a small electrode, I guess, is attached to the tragus, which is that little knobby thing in front of your ear, and it was stimulated. So a small randomized controlled trial was done in 2023 with only had 26 participants, and they stimulated the tragus part of that ear there. I'm not sure how often it was done, but the people were tested again at 2 months, and they found quite a lot of improvements overall. But it obviously was not a big enough trial to come to any really formal conclusions, apart from the fact that they recommended further studies. I do know that some people swear by it, and I've heard of some people having that part of their ear pierced and saying that they found huge benefit. But again, it's not mainstream yet, it's not proven. But there is definitely information out there on the internet for people who are interested and want to look further at it. So just to finish off with a few resources, there's a lot of information out there, and a lot of good resources available for people. If you wanted to find out more, there are definitely places to go. Does anyone have any questions or want to make any comments?
Yeah, thank you very much for this. It's been very interesting. I want to thank you in particular for the awareness that electrolytes are available in prescription.
Oh, right.
Very much over summer with this.
Right.
Even with drinking enough water, that's going to be very helpful.
Yeah, water alone is probably not enough, because it just tends to be water in, water out, doesn't it? And you really need that sodium to hold that fluid in your body. So And I know that people have said as soon as they stop the electrolytes, they notice a big difference in how they feel. So, yeah.
Yeah, my doctor said about increasing salt in the diet, that was okay, and I do notice a difference with that, but I think like the electrolytes might make a difference as well. I did want to say with the bit at the end about the tragus and the piercings, and there's also the daith piercing for migraines. These things were started by piercers, so people selling the thing based on no evidence.
Right. Yes. Yeah.
Yeah.
Yes. Yeah.
Although there has been little studies, you can't exactly placebo it.
No, you can't. That's right. It's a bit hard to. You're right, actually. It's definitely hard to do a placebo with that for sure.
Yeah.
But I think that trial that they did in 2023. So the trial authors are there on that slide if you wanted to go back and have a look and just sort of have a look for yourself. And they did actually show some quite good results, but it's just not enough people. It's just not enough people to really be definitive, about it.
Yeah.
So yeah.
No, it's very helpful. I've been wondering about my own issues with standing up and falling over, and this was a helpful bouncing off thing to go and look into it further. Thank you.
No, that's right. You're very welcome. Thanks for that. Cool. Anyone else had any comments or?
Yeah, I guess I'm at the stage where I have been doing a little bit of exploration in terms of POTS, and I haven't had the diagnostic testing yet. I've done a little bit of I've got a smartwatch and I've done a little bit of testing myself, and seems like I go my heart rate increases by 30, but potentially I haven't got that high heart rate necessarily because I've got quite a low resting heart rate.
Right.
But yeah, so I was just wondering, I mean, my plan is to get the testing done, but you did mention that 60% of people with ME, they have that low orthostatic tolerance, but they're not going to necessarily meet the criteria for those sorts of different POTS diagnoses. But I mean, if you've got the symptoms, is it suggested to actually just try out these different methods and see what helps?
Yes. Yeah, definitely. I think definitely go for it, because even if you don't have a diagnosis, what you're needing to do is to improve your brain perfusion and things like that. So, even starting with the fluids and the sodium, increase to see if that makes a wee difference. Try compression garments, all of those things will help brain perfusion. So definitely give it a try. And if you wanted a test, we do offer them. We can do them. We can come to your home and do a nasoline test for you. The benefit, I guess, of having a test is it will tell you definitely one way or another whether you have POTS. And if you do have POTS, then you can have as another option for treatment, you can go for medication as another option for treatment. Whereas if you're symptomatic but you don't have meet the criteria, you're looking more at the non-medical medication, the non-pharmacological treatments. Yeah. But definitely, give things a try, and probably the fluids and the sodium would probably be the number one thing to try, and probably the thing that's most people say it's big impact for little investment, basically. Yeah.
I think what I've struggled with is I've been trying to up my electrolytes and trying with the liquids. So as a first port of call, but it's like just that severe dehydration is still quite constant. But I do think looking at those numbers, potentially the salt, is an area to look at.
Right. Yeah. Cool.
Sorry. I was just going to say with that, it's really good even if like you're buying your own electrolyte sachets to make your own electrolyte drinks, to look at the amount of individual ingredients, like to look at the amount of salt compared with the amount of potassium and sugars and stuff in it, because I think that's where I've struggled in the past. I've brought electrolytes, but they perhaps not have the right amount of salt in them. But
Right.
I also just wanted to say thank you for this. Sorry, I'm a bit foggy today. But what was I going to say? I was going to ask where we could find this presentation.
Right. Okay. So it's being recorded at the moment, and it will be put onto our website.
Okay.
Yeah. So it'll be uploaded within a little while. And as I said, we do have other resources as well. Just particularly if you wanted to find some good basic resources, if you go to Bateman Horne Centre, the Bateman Horne Centre, that's a very good evidence-based research centre in the United States, and they have quite a good section on orthostatic intolerance and management of it. So that's probably a good place to start if you wanted to just go online and have a wee look. Yeah.
No, I have. Yeah, I need to look at more of their resources.
Yeah.
I've been diagnosed for over a year now, but I'm sure I had POTS when I was at high school as well. But I was just told that I didn't want to walk home and that I was just anxious, and that's why I was so dizzy.
Right.
So yeah, it's a journey that I'm still going on. But yeah, thank you so much for this.
No, that's right. You're very welcome. So that's it. So thank you very much for listening, and I hope that you found that some of it's interesting and helpful.